Alright, this video is going to describe single case designs. These are sort of like case studies, but they utilize interrupted time series data to make conclusions about causal inference. So of the four designs that we've used, there are statistical analyses. 3 out of the 4 designs that we've used, the regression discontinuity, quasi-experimental, and randomized control trials, would use statistics to determine the effects. And in single case research, we don't use statistics necessarily. We look at the visual analysis of graphed data. And so this is going to be a brief overview of what single case research is and the standards that we use to describe them, and then there will be some more videos that will go into further detail from the Institute of Education Sciences. Again, those videos are best seen or viewed in Safari on a Mac. For whatever reason, Chrome on a Mac just doesn't want to play Flash embedded videos, so you need to open it up in open those videos in Safari rather than in Chrome. So there are 3 defining features of a single case design. An individual case is the unit of intervention, administration, and data analysis. A case may be a single participant or a cluster of participants, for example, a classroom or a community. Within the design, the case provides its own control for purposes of comparison. For example, the case's series of outcome variables prior to the intervention is compared with the series of outcome variables during and after the intervention. The outcome variable is measured repeatedly within and across different conditions or levels of the independent variable. These different conditions are referred to as phases, e.g. baseline phase or intervention phase. An example of this would be in my papers. Sorry about this. So an example of a single case design results would look like this, where there we go, where we would see a graph, and over a certain number of days or a certain number of observation periods, this is the baseline phase. And so we get a notice, we can notice trends, we can notice variability, we can notice the level of the data points. And then post-intervention is actually here, so we have these lines, and this line is depicting whether or not we're in baseline. And then we have this is actually during the intervention, so we actually plotted so the intervention took 5 days, so we actually plotted 4 days out of the 5, and then we have a post-intervention, which is going to plot the data points for post-intervention. And so we're using repeated measures of in this case we made a bunch of different versions of a fractions measure, and so there were 12 questions on each measure, and so each day they would be given this fractions test, and we made between 12 and 15 different versions of the test so that they weren't being tested on the same problems each time. And so throughout the course of the intervention, we can notice a differentiation between the level and trend and variability of the data from the baseline phase, which is our control phase, to the intervention phase. So a background on the single case design. We look at repeated measurement of an outcome before, during, and or after active manipulation of the independent variable. So we're looking at repeated measure of fractions probes, let's say, and we look at that prior to and then after the intervention has been delivered to see whether or not there was a change. This allows for the study of low prevalence disorders where otherwise we would need a large sample for statistical power. In cases of students with emotional disturbances or students with autism, there's not so many of them that we can do a randomized control trial, so we often look for we look for this design to be able to tell us something about whether or not this intervention works for a group of students when there's not a lot of students to look at. It is sometimes more palatable to service providers because single case designs do not include a no treatment comparison group. Descriptive analysis of single subject research designs from 1983 to 2007. This was a... Oh, those are just references. Sorry about that. Like randomized controlled trials, the purpose is to document causal relationships. We control for major threats to internal validity through the use of the design. We document effects for specific individuals and settings. We replication is then required to enhance external validity, and this can be distinguished from case studies. So let me go back a little bit. We control for most major threats to internal validity just by using the repeated measurements of and the requirements of the single case designs. And so maturation is thrown out because we're using, repeated data points, and history is thrown out because we would see something. The historical event that we're supposed to be seeing is this intervention. And so it controls for a lot of these threats that we might have in a larger trial just through the repeated measurement of the independent variable or of the dependent variable, and also through replication from one area, from one student to another, or from one phase to another. We distinguish this from a case study because we are looking at more than a description of, more than just a simple description of what ended up happening, and we're actually able to use quantifiable data to show this design. So what do we need? We need professional agreement on the criteria for design and analysis of single case research. We could use better standards for training in single case methods. Again, this is just this training, so to speak, that you're going through is a it should give you enough information to be dangerous, but it's not all the information that you would need. It would, if you were going to be doing a single case design for your dissertation or for a study, it would be within your best interest to not just rely on this video and the module that's within here, but that you actually get one of the books. And the best books, there is a book by Gast and Ledford. Where is it? Gast and Ledford, Single Case Research Methodology. And then there is a book by Kasdan, which was 2011, and that's called Single Case Research Designs. We need better standards for reviewing single case intervention research. This falls on the topic of journal editors or reviewers. We need to develop an effect size and meta-analysis technology. We have these things, but we have a plethora of these things, and so it would be nice if we came to a consensus on one measure. So applied behavior analysis is where all this stuff came from. And so we still see that randomized controlled trials are the gold standard of applied research. And they used to formally dismiss single case research, but now recent investment by IES and a couple of the other things have allowed us to both use single case designs in the for grant funding, and that we can also use it for determination of evidence-based practices if we have enough of them. So if you did a huge randomized controlled trial, we could call that an evidence-based practice. However, if we're doing a single case design because there's only going to be 1, 2, 3, students, we need to have enough replications of the intervention effectiveness of the study, essentially, that would allow us to be able to say whether or not this thing was an evidence-based practice. So the types of research questions that can be answered with single case designs: we can evaluate intervention effects relative to baseline. So, for example, does this intervention reduce problem behavior for the participant? We can compare the relative effectiveness of two interventions. So is intervention 1 or intervention 2 more effective at reducing problem behavior for this participant? And we can compare single and multi-component interventions. Does adding intervention 2 to intervention 1 reduce problem behavior for this participant more than intervention 1 alone? And so we see in this example graph, up here we would have the conditions. So the baseline would go here, the independent variable essentially goes here. So we can see that this was at the control or baseline condition, and then this was in the post-intervention. We need to have a change line here, and then we have our data points here. We have our unit of time going across the bottom, and the measurement of the dependent variable listed along here. So again, we have baseline treatment, baseline treatment. So this one is a simple, what we call A-B designs, where A stands for baseline and B stands for intervention. So this one here, we have a A-B design, one of the first designs that we looked at when this all started. This was the most common, as this was used in applied behavior analysis. A lot of things that would end up happening is that, so if we don't do anything with the child, this is what we end up with. Then we do something with the child and we end up down here, and then if we can take that thing away, we can go back up to baseline and then show in a replication that it happened here. So in this case, in an ABAB design, we only need one student or one class or one case in essence, because we've replicated it here, here, and here. So we see that the intervention worked at reducing the problem behavior, and then when we take it away, we see that the intervention, that we go back to baseline levels, and that as we reintroduce it again. So we see that the effectiveness of the treatment happens at 3 different points in time. So the design allows for documentation of a causal relationship between independent and dependent variables, and what we call this is a functional relation. So if we see 3 demonstrations of an effect along here, we would say that there was a functional relation between the between the introduction of the independent variable and scores on the dependent measure. The individual provides their own control. We can treat a group as a participant with a focus on the group as a single unit. The independent variable is then actively manipulated. We put the intervention out there, and then we can take it away, we can put it back out, we can take it away, and we see what that does to the graphs. We use repeated measurement of the dependent variable, where direct observation at multiple points in time is often used. We use inter-observer agreement to assess the reliability of the measurement of the dependent variable. So very often this is going to be a behavior, and by behavior it could be anything. It could be task engagement, it could be but the behavior could also be performance on a math measure. So we talk about behavior as being something that is observable. We use baseline to document the social problem and control for confounding variables. So that controls for maturation by doing the baseline. We have an opportunity for replication of the basic effect at 3 different points in time, and this is going to be something that we talk about when we look over the 3 overarching designs of single case design, that we need 3 different points in time to show a replication of the basic effect, which gives us the functional relation. Then we have visual analysis, which documents the basic effect at 3 different points in time, and we have statistical analyses that are emerging but not something that we really want to talk about here. We have systematic replication within a study to document experimental control, and that systematic, it could be the ABAB design, it could be an AB design delivered at different points in time, which we call a multiple baseline design. So we're looking at within a study to document experimental control, across studies to document external validity. So how many studies have we seen of FBA research for severe problem behavior? Do we have enough of them to be able to say, yes, this is a generally effective method for treating problem behavior? And then we also want to go across studies, researchers, context, participants to document evidence-based practices. Because one of the things that we'll see is that you'll see that a lot of times the same researchers are doing the same things. So if we're looking at self-injurious behavior, it might be that all of the FBA literature on self-injurious behavior is done by one research team or members of the research team. And so what we want to do is we want to be able to look at it and say, okay, the replications need to be by other researchers, because if only these people are able to get it, it calls into question whether or not we can reliably look at that as an indicator. So if the only mathematics if the only SRSD mathematics studies that are out there are by me and people affiliated with my research team, I want somebody else to be able to replicate and find the same results, because it adds credence to what I've been doing. And we have flexibility. The designs may be modified or changed within a study. So the design examples, we have a reversal or withdrawal design, and that was the first one that I showed you, which is up here, where we have an A phase, a B phase, an A phase, and a B phase, all within one study, essentially. So this is all one case. Then we have multiple baseline designs, which are going to be an A-B, but delivered at different times. So the A phase is here for this student, and then the B phase. And then we wait a few days, and we keep collecting baseline data for everybody else in the A phase, and then the B phase. And this shows us that, again, we're looking at, was there an immediate change when the intervention took place? So we have this happening here, and then this happened. And then at a different time point, it still happened. And then at a different time point again, it still happened. And then at the final outcome, it still happened. And then the last one that we're going to look at is the alternating treatments design, where treatment 1 is looking down here, and then treatment 2 is up here. And so we can see that this treatment, if more is better, then this treatment was better. Although if this was disruptive behavior, we would actually want to see it go down. So then this treatment would be better. So single case designs are useful in the iterative development of interventions. They're useful in design of any interventions focused on the individual participant, especially with low incidence populations. They're useful for pilot research to assess the effect size needed for randomized control trials. And they're useful for fine-grained analysis of weak and non-responders or negative results. So again, here's the AB design. Get rid of that. So we have A phase, B phase, A phase, B phase. Then we have the alternating treatment or alternating intervention design, where we would have baseline, then we do the interventions and we see which intervention ends up being better. And generally speaking, we'd like to see that that intervention was continued, so that this wasn't confounding what was happening here, because it could be that this was aversive, and so by delivering the intervention here and then delivering the intervention here, the student liked this one better, so then this could have, who knows, confounded the results. And so we would want to see that this intervention lasted on its own. Then we have the multiple baseline design, where again we are staggering the start times for each participant so that we could see the effects at each different start time. And so we have 1, 2, 3, 4 replications within the study. On this one we have a bunch of replications because we're going back and forth and back and forth and back and forth. And on this one we have the 3. We have here, we have here, and we have here. So single case design standards are designed to address threats to internal validity. This includes ambiguous temporal precedence, which means A preceded B or whatever. It deals with selection bias, because we are looking at a single case and we are saying this is what happened in this particular instance for this person. It deals with history because we'd see it in the graph. It deals with maturation because we would see it in the graph. It deals with testing effects because we would see those in the graph as well. So if they were getting better just by being given this instrument, we should see an increase throughout baseline that would give us an idea that this would have kept on happening. Instrumentation, we're using inter-observer agreement to be able to determine that our measures are reliable. And then the additive and interactive effects of those threats. So what are the types of questions a single case design might answer? Which intervention is effective for this case? Is the intervention more effective than the current baseline or treatment as usual condition? Does adding B to intervention A further reduce problem behavior for this case? Is intervention B or intervention C more effective in reducing problem behavior for this case? And so when we look at the evidence standards, we can see that we can go from strong evidence, moderate evidence, to no evidence, and then if we have strong or moderate evidence, we would then calculate some sort of an effect size for that, although the field hasn't decided which effect measure is the best, so that one is a little bit out there. So the criteria for SCDs: the independent variable must be systematically manipulated, the outcome variable must be measured systematically, the study must include at least 3 attempts to demonstrate an intervention effect, and the phase should typically include a minimum of 5 data points. We can get below that number of 5. It should be over 3, but we can go under 5 if we say something to the effect of, by giving this probe this many times to this student, we are introducing them to, we could see test fatigue. So if I give them a math test every day for 20 days, they might get over taking that test, and we would have to account for that. And so we can reduce the amount of data points that we are taking, but we need to have at least 3, preferably 5 data points within each phase. And what that essentially means is that when we look at the multiple baseline, that we should have 5 here, and then 5 more before we do the next treatment, and then 5 more before we do the next treatment, and then 5 more before we do the next treatment. The researcher then determines when and how the independent variable conditions change. The outcome variable must be measured systematically, measurement occurring over time. Inter-observer agreement is reported. Inter-observer agreement must be assessed on each outcome variable in every phase, and there should be measurement for at least 20% of the sessions distributed across all study conditions. So we need to do 20 sessions. So if there's 20 data points, we needed to collect inter-observer agreement on at least 20% of those. So I usually randomly assign them, and so we would want to look at 1 or 2 in baseline, 1 or 2 or 3, and so what would 10%, 2, 4. So we would be looking at least 4 of the 20 observations that we did would need to be assessed by someone else. Designs that generally meet this standard: ABAB designs, the standard of having 3 attempts to demonstrate an intervention effect, multiple baseline designs with at least 3 participants, and alternating interventions or alternating treatments designs. Designs that wouldn't meet this are an AB design, because we would only be looking at the effect happening once. An ABA design would happen twice, and a BAB design, again, would happen only twice, but we wouldn't be starting with a baseline phase, because remember, B is an intervention. So we have our first demonstration of effect, we have our second demonstration of effect, and our third demonstration of effect. And we also have the amount of data points that need to be in each one of them. Looking at the multiple baseline design, we have a demonstration of effect here, 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 and then we actually have one more here. The phase should typically include a minimum of 5 data points. Exceptions: if an ABAB or multiple baseline design study has fewer than 3 or 4 data points in any one phase, the study may meet evidence standards with reservations. So this is the What Works Clearinghouse's guidelines on what is appropriate and what is not appropriate. And we like to use that as a gauge for when we're designing a study. We'd like to see that we're meeting these standards, and then if something happens during the study that makes us have to change things, then we can, but we don't want to change too many things, because then we're getting into a suspect design issue. If we're doing things like a brief functional assessment or alternating treatments design or randomized designs, the 5 data points, we might want to do more than that, we might want to do less than that, it just kind of depends. But this is more for doing a brief analysis of something rather than doing a full-on study. And so one of the things that so when we look back at if I were doing something where I was going to utilize this rule, I gotta find Okay. This phase is just detailing whether or not we still have a baseline phase, we still have an intervention phase. This phase is just detailing which we're going to use in the subsequent phase. And so we might say that we don't need more than 5 data points here, because all it's doing is telling us which one works better. And if we're looking for, does this intervention work as opposed to baseline, we're really using this versus this rather than this versus this, if that makes sense. So we use visual analysis of graphed data to make our decisions. The Walrus Clearinghouse reviewers have been trained in visual analysis of data. However, visual analysis is not without its flaws, and we have very low correlations between what some people will call a functional relation and what other people will call a functional relation. So it's a little messier than group design statistical analysis, because we're making judgments rather than having a test that tells us one way or another. So we want to define 6 variables used in visual analysis and build fluency in applying those variables with attention to both main and interaction effects. We want to provide a 4-step framework for analysis of single case designs through visual and statistical analysis, and apply visual analysis to ABAB multiple baseline designs and alternating treatment designs. So we need to have 3 demonstrations of effect at 3 different points in time. A basic effect is a change in the dependent variable when the independent variable is actively manipulated. To assess an effect, visual analysis includes simultaneous assessment of the level or the mean, the trend, the variability, the immediacy of effect, overlap across adjacent phases, and consistency of data pattern in similar phases. So interpreting experimental control always involves assessment of data from the whole study, all phases, not just assessment of 2 adjacent phases. Assessment of a basic effect is done with adjacent phases. Assessment of experimental control requires evaluation of all data in all phases. So we have a basic effect when we have the simple ABAB design. So basic effect here. Functional relation then is made when we have a basic effect along 3 opportunities. Okay. So the 4 steps. Do baseline data, document a predictable pattern. And I want to bring up that study that I used, where if I were to hypothesize where my next data point would be, I would surmise it would be around here, maybe a little bit higher, because we have an actually increasing trend. And what we would like to do is we wouldn't want to start the intervention if this trend is decreasing. We only wanted, or if this trend was continuing to increase. We only really want to do it if this is plateaued or if it's decreased. Now, the reason that I made the determination to start the intervention when I did in this is that if we go down to the schools, these are individual participants at school 1. So we can see this is school 1, the first 3 people, and then, or the first 2 people, and then the second 2 people. And we can see that we're leveling off here and it's not going up. It was just the mean was showing a trend upwards. And so I made the decision at that point that we could go ahead and start the intervention. So we can also see here that it's starting on a downward trend, so we could start the intervention here. And here it's starting on a slightly downward trend, and so we could go ahead and have no problem starting the intervention. This one is the one where we would have to say, well, should we collect another data point and hope that it levels out or goes down before we start the intervention? And I made the decision to go ahead and start where we were. But it's important to note that the trend, where this is it going in a direction where we could plausibly say that these data points didn't happen because this was going up and it would have happened anyways. We can see that here we're seeing a large jump, and so I feel pretty good about it. But again, this is one of those things where people are going to make judgments, and then reviewers are going to call you out and those kinds of things. So it's important to reconcile those things. Do data within each phase allow documentation of a predictable pattern? And that's a pattern of level, trend, variability, overlap, immediacy of effect, and consistency across similar phases. Do data between phases document basic effects? And then do data across phases document experimental control? So we would do these things in step. So we look at baseline, and then we look at the patterns between so looking still for basic effect. Do data between phases document basic effects? Do data across phases document experimental control? And that's where we look for 3 basic effects. So for multiple baselines, we want to look at stability in non-intervened series when effect demonstrated in one series. And so when I bring it back, so we want to know, once this phase increased, was there a jump here? And that would tell us whether or not there was any contamination that happened between giving this person the intervention and this person. So it may be that this person saw what was happening in this one and thought it was a really good thing, and so their scores might have increased, and that would be a historical threat that we want to rule out. So we look at making sure that this is being maintained while this goes on. So if I had chosen not to continue to test this person, I would have tested them all the way up until this point, had a data point at that phase shift line, and then I could have not given them and then just done, so I could have eliminated essentially this one. And that would have told us, well, at the phase change, this remained constant, and then we were still pretty good right before we did the next intervention. And then the same thing could have been done for this, where we would have just had this point, this point, this. We could have gotten rid of this one because it's not at a phase change, and we could have gotten rid of a couple of these that weren't at phase changes as well. So when we are looking at alternating treatments, we want to see, is there a huge difference between the two conditions, larger than the demonstration of a functional relation? Is there greater consistency of separation between the two conditions? For example, no overlap, larger the demonstration of a functional relationship, or relation, don't say relationship, say relation. And the more points documenting separation to larger the demonstration of a functional relation. So when we look at evaluating the quality of single case designs, 4 standards for design evaluation, where we're looking at the systematic manipulation of the independent variable, inter-assessor or inter-observer agreement, 3 attempts to demonstrate an effect at 3 different points in time, and a minimum number of phases and data points per phase for phases used to demonstrate an effect. So the researcher must determine when and how the independent variable conditions change. If the standard is not met, the study does not meet evidence standards. So typically what I will do is I will either say that we are going to do it based on the data, and once we have found a stable and level trend in the data, then we would go ahead and implement the intervention. The other way that it could be done is that you could randomize the start dates. And so generally speaking, I would randomize over 3 days so that we at least had 3 data points before, and then we could randomize the start times for each of the individuals after that. And that allows for us to be able to make a decision before we started the intervention. Examples of manipulation that is not systematic: teacher consultee begins to implement an intervention prematurely because of parent pressure, or the researcher looks retrospectively at data collected during an intervention. Standard 2, inter-assessor. Each outcome variable for each case must be measured systematically by more than one assessor. The study needs to collect inter-assessor agreement or inter-observer agreement in each phase on at least 20% of the data points in each condition. The rate of agreement must meet minimum thresholds. For example, 80% is what we're looking at. Determine if standard is met based on response. What are we looking at here? Oh. So here we're looking at, did this study look at 3 demonstrations of effect at 3 different points in time? And we're looking at ABAB designs, multiple baseline designs, and alternating treatment designs. The ABAB design has gone out of favor because we in order for this design to work, we have to be able to get the person to go past or to pre-baseline or to baseline effects, which means that if we were doing self-injurious behavior and we fixed it, we would actually have to take away whatever it was that fixed it and let them go back to self-injuring, which obviously has ethical implications. And so, generally speaking, the most utilized design anymore is the multiple baseline design, because it doesn't take into effect the ethical questionability of, is it even possible to take away that intervention effect? And even if it is, should we? So the minimum number of phases and data points per phase. For a reversal design, we want 4 phases and at least 5 data points per phase. And for a multiple baseline, we want 6 phases with at least 5 data points. So this would be 3 students, and this could be with 1 student. And for an alternating treatment, at most 2 per phase, at least 5 per condition. So here we have 4 phases with at least 3 data points per phase, because we didn't have 4 here, or we didn't have 5 there rather. And then here we have 6 phases with at least 5 data points per phase. So we had 1, 2, 3, 4, 5. So we're good. Although, yeah, I think we're okay. We should have probably waited a little bit longer between these, but I think it's okay. And for an alternating treatment, we have 1, 2, 3. It gets kind of complicated. So we would say that a design meets standards if the intervention was manipulated directly, if the IOA was documented at 0.8 or higher with 20% of data points. I usually do 30%, but 20% is okay. Design allows opportunity to assess basic effect at 3 different points in time, and 5 data points per phase, or whatever we have decided there. And then it would meet with reservation if it met all of these things except at least 3 data points per phase. So the thing that we want to recognize about single case designs as opposed to group designs is that we're going to have different information within our method section. And so what I would request that you do is that you find a single case design study that that you can read over, and preferably one that was done subsequent to 2010. So if I bring up that study again, the main thing that we're going to be looking at that is going to be different is the data analysis plan. Oh, there we go. The data analysis plan is basically going to say that we, looked at the variability of the trend of the data and that, and those types of things. The other aspect of this that we would want to look at is what we do with our participants. So this one's not a very good example, because generally speaking what we would do is once we had the participant, we would set up the setting and the sampling procedure, but then in our participants we would generally have a heading for each participant that would give like their age, their gender, their socioeconomic status, anything that would be relevant to so gender, age, race, ethnicity, free or reduced price lunch, disability, and then their risk status. So this would be put essentially into a paragraph form for each student. For this one, we were doing it by school, so that wasn't necessary. But generally speaking, we would see a single case design that would look like, where would it be? Oh, I can find one here. So in this manuscript, If I go down to participants, you will see that, and don't ever use their real name. Rihanna was a 10-year-old female student of American Indian descent. She was receiving special education-related services due to academic and behavioral needs, including physical therapy. Additionally, she was a child served at the states. And then we talk about how we, and then we would do that for each student. Then when we provide the results of the study, we do essentially the same thing where we list the results by student. So we have we have a paragraph that kind of discusses the results in general, and then one for each of the students. Single case designs are really quick and easy ways of delivering these things. When you write up your study or your write-up for this portion, I would recommend that you read a couple of single case design studies beforehand so that you get an idea of the slight variations in the methodology that we look at. All right.